Hello, everyone. I hope you enjoyed your lunch and welcome back to Planet MicroCap 2024. Now we have with us Eric presenting Atossa Therapeutics.
Thank you. Thank you, and thanks for everyone for joining today. Atossa Therapeutics, I'll just give you a little quick history on the company. Founded about a dozen years ago by Dr. Stephen Quay. He had this really novel idea to develop the pap smear for breast cancer. So the pap smear looks at, it's not really looking for cervical cancer, it's looking for changes that are happening that are going to lead a woman to developing cervical cancer. And it's that same process that happens with breast cancer. So breast cancer development is sort of a 10-year window. It starts with some cells doing some weird things, and then there's a process that goes on for about 10 years before a woman will be diagnosed with breast cancer. And his idea was to identify that process as early as possible and then develop a therapy that could prevent it from moving forward. So that's really where the company got started. And now we're both in the prevention and treatment setting of breast cancer. So we're a publicly traded company. Forward-looking statements you can find on our website and all of our SEC disclosures. So I'll mention just quickly, my colleague Heather Reese is here in the back of the room. Dr. Quay, he had earned his MD, PhD, both at the University of Michigan, did postdoc work at MIT, and taught for about a decade at Stanford. He's also developed 6 drugs from the back of a napkin idea through to commercialization. He wasn't there for the commercialization of those drugs. The companies were all sold prior to the drugs becoming commercially available, but about 80 million people have benefited from drugs he's invented. All right, this is not, okay. So I mentioned breast cancer, that's the focus of the company. I'm sure everybody is aware of somebody, unfortunately, who's been touched by breast cancer. About 13% of the women in the world will develop breast cancer in their lifetime. In the US alone, there's over 300,000 cases diagnosed annually, and 80% of those cases are what's called estrogen receptor positive. So estrogen receptor positive breast cancer requires estrogen to grow. The estrogen in your body actually fuels the cancer. And that's primarily the type of cancer that we're focused on currently. I don't know what I'm doing wrong here. Oh, okay. So breast cancer, the breast cancer continuum, so it starts with prevention, obviously. We have 2 ongoing prevention trials. One that's looking at reduction in mammographic breast density. So breast density, about half the women in the world have dense breast tissue. It is the most significant independent risk factor for developing breast cancer. Women with the highest density have upwards of an 8 times higher likelihood of developing breast cancer in their lifetime compared to women with the lowest density. So the idea is to reduce density and reduce the incidence of breast cancer. We've also got a study looking at DCIS, ductal carcinoma in situ, which is the earliest form of breast cancer. It's when the cancer cells are still contained within the milk ducts of the breast. Only less than 50% of women diagnosed with DCIS would ever advance to having invasive breast cancer if left untreated. Unfortunately, we don't know which those women are. So all women diagnosed with DCIS are treated as if they have invasive breast cancer. So they undergo surgery, either a mastectomy or a lumpectomy, chemo, radiation, and for many women, 5 to 10 years of endocrine therapy in the adjuvant setting. So we have a study that's looking at, can we treat them with endoxifen for a period of 6 months and then monitor them for 3 years and see if they advance or if they don't. And if they do, which women are advancing, which women are not. And then maybe we could use endoxifen as a treatment for a percentage of women diagnosed with DCIS. We're also looking at treatment in the neoadjuvant setting. So that's the window of treatment or window of time between diagnosis and definitive treatment. So in the case of breast cancer, definitive treatment, or invasive breast cancer, the definitive treatment is typically surgery. So can you treat the cancer before you have surgery? The idea being to downstage, slow the growth of the tumor, downstage, shrink the tumor, which makes surgery more effective and lowers the incidence of recurrence. The other opportunity is in the adjuvant setting, so the setting after surgery. Most women's standard of care for women diagnosed with ER-positive breast cancer is to have some sort of endocrine therapy for 5 to 10 years after surgery to reduce the incidence of recurrence. The drug that's standard of care now is called tamoxifen. It unfortunately has a pretty significant adverse event or safety profile. Many women stop taking the drug because of there's compliance challenges associated with the adverse events. Most women get vasomotor symptoms, so night sweats, hot flashes, joint ache, headache, and they'll just stop taking the drug. So obviously, if you're not taking the drug, the efficacy is not going to be there. The other problem with tamoxifen is that it doesn't work in premenopausal women without ovarian suppression. So premenopausal women are required to take another drug to effectively shut their ovaries off from producing estrogen, put them into menopause. So we're looking at endoxifen, our drug, in premenopausal women without the requirement for ovarian suppression. And then the last piece is the metastatic setting, and we don't have trials in the metastatic setting yet, but we are looking in particular in combination. We just announced some preclinical work in combination with ADCs. So we're hoping if this preclinical work shows what we expect, that we would be in the metastatic setting maybe as early as later this year. So endoxifen is a selective estrogen receptor modulator, meaning it blocks the estrogen receptor on the breast cancer cell and doesn't allow estrogen to get there to fuel the cell. So the receptor is a pocket and the estrogen fits into the pocket. Endoxifen blocks that from happening. It also degrades the receptor, so it'll start to break down the receptor so that if any estrogen were to get through, it's not able to get into the cancer cell. And then at a higher dose, we're learning more about this just recently, but at a higher dose, it can inhibit a pathway called PKC beta. And what it can do is it can kill the cell. So it induces apoptosis, which is programmed cellular death. It causes the cancer cells to commit suicide, for lack of a better term, and it kills the cells. So the drug has been studied in a number of trials and at a variety of doses up to 160 milligrams a day in humans, and there's no concerns from a safety or tolerability issue. It also, obviously, like I mentioned, it can be used in premenopausal women without ovarian suppression. We've also have 3 issued patents in the United States, one around composition of matter, so the white powder, one around formulation, how it's put together, and then another around methods of use. So 3 issued patents in the U.S., a number of other patents that are pending in the U.S. and across the world. So we have 5 ongoing phase 2 trials, 2 in the prevention setting, 3 in the treatment setting. I already talked about DCIS. The mammographic breast density study, okay. So it's called the Charisma Endoxifen study. It fully enrolled in November of last year. It's a pretty straightforward study. So we're enrolling women who have elevated breast density. They're having a mammogram on enrollment, a mammogram at 3 months, a mammogram at 6 months. It's a double-blind placebo-controlled study. There's 3 cohorts. There's a placebo cohort, 1 milligram a day treatment cohort, 2 milligram a day treatment cohort, and we're looking at reduction in density over the course of that 6-month treatment period. There'll also be a follow-up mammogram at 24 months to assess the durability of the reduction. We should have the data from that, fully enrolled in November, 6-month treatment window for that last patient. That gets you to May, so we have a month or 2 to analyze the data, and we should have it early in the fall. Just visually, this is what density looks like. So mammograms today are able to give a percentage of density, and they look at it by BI-RADS. So 0 to 25% on the left, 26 to 50, 51 to 75, 76 to 100. And the concern with women with the higher density is not just that they have a higher likelihood of developing breast cancer, but when your breast density appears white on a mammogram, as does cancer. So it makes it very difficult to identify cancer, particularly early. So women with the highest density tend to get, if they do develop breast cancer, they tend to get developed in that interval between their mammograms, and the cancer is far more advanced, which makes it harder to treat and has suboptimal outcomes. So our opportunity with endoxifen is to reduce density and bring the women with the higher density down this scale. So again, we'll have that data in the fall. The other thing, just from a timing perspective, that is really interesting is that on September 10th of this year in the United States, a federal law goes into effect requiring mammogram facilities to notify women of their density following a mammogram. So for the first time, there'll be federal legislation that when a woman has a mammogram, they'll get a report that says, you know, your mammographic breast density is X. Above 50% means you have a higher likelihood of developing breast cancer. Mammograms are far less effective, and you should go speak to your physician. Right now, there's no approved treatment for reduction in density. So if you live in the right socioeconomic zip code and you have the right insurance, there's an opportunity to potentially go get an MRI or an ultrasound. But for most women, that doesn't happen. So we're hopeful that there'll be this increased awareness around density right at the same time that we'll be bringing out, you know, our reduction in density data, and then we'll move forward with some sort of phase 3 registrational trial. Understand what I'm doing here. Okay. So the first of the neoadjuvant studies I want to talk about is our Evangeline study. So this is a study, again, ER positive, estrogen receptor positive, premenopausal women diagnosed with breast cancer. We're treating them in that window between diagnosis and definitive treatment, which is surgery. We started with 40 milligrams a day. The idea being we wanted to get to 500 nanograms per milliliter of steady state plasma concentrations. That's where we know we can most effectively target PKC beta, where we can hopefully induce apoptosis and kill the tumor. We started at 40 to see if we could get to those levels. As we announced recently, we didn't quite get to the steady state plasma concentrations we were looking for, so now we're looking at 80 milligrams a day. But we do have the data from the 40 milligram dose. The endpoints we were looking at is reduction in Ki-67. So Ki-67 is a proliferation marker. It basically says how fast the tumor is growing. And we were also looking at MRI. So we wanted to see if we're able to shrink the tumor burden. So we announced this at a conference just last month. Ki-67 at 28 days, so there was a reduction. It was a 7-patient cohort, a reduction of 56% across the 7 patients at 28 days. So after 28 days of treatment, 56% reduction in the growth rate of the tumor. After 6 months of treatment, there was a 92% reduction in the growth rate of the tumor. So the tumors effectively stopped growing. We also saw shrinkage, so tumor shrinkage. At 3 months, at the top 12 weeks, we saw a complete response and then significant response across the other patients. So 32% reduction across the board. At 6 months, we saw a 37% reduction. And I spoke earlier about the safety profile. There were no grade 4 or 5 adverse events. There was 1 grade 3 headache and then a couple of grade 2 adverse events or tolerability concerns reported by patients. But for the most part, very safe, very tolerable drug. The 80 milligram cohort is enrolling now. So we hope to have that PK data either this quarter or early next. And then we'll have the efficacy data at some point, either late this year or early next. The other study that we announced just this year is a combination study with a drug from Eli Lilly. It's a CDK4/6. It's about a $4 or $5 billion annual revenue drug for Lilly. It's used in combination now with either fulvestrant or tamoxifen, 2 hormone therapies in the adjuvant and metastatic setting. It's not approved in the neoadjuvant setting where we're looking at it. The idea here would be for women who have really high tumor burden, significant lymph node involvement, that maybe the combination might be a better option in the neoadjuvant setting. So this study is underway now. We're enrolling patients. It's being run through this group called the Quantum Leap Healthcare Collaborative, which is a network of oncology centers. They have access to a network of oncology, the 41 largest oncology centers in the United States. So we expect it to enroll relatively quickly. It's only going to be 20 patients. We should have the data at some point next year. So just real quick, 5 ongoing phase 2 studies. We'll have the mammographic breast density data early fall. There's another neoadjuvant study, 10 milligram monotherapy study, which fully enrolled in February. We'll have that data also in the second half of this year. We'll have treatment updates, we'll have the 80 milligram PK data hopefully this quarter, early next, and then enrollment updates across the other studies. From a sort of financial perspective, as of the first of this year, we had $88.5 million in cash. We have no debt, and there's warrants outstanding, exercisable between $1. There's about 11 million between $1, $1.05, another 10.5 million closer to $3, and then options. So if those are exercised, it would represent another 50 to $60+ million in cash. So that's it. But happy to answer any questions. Yep. Not that we're aware of in breast density. So tamoxifen, the standard of care for it, has been looked at in. So it has an indication, approved indication for prevention of breast cancer in a very high risk population. Hardly anyone, if anyone, takes it because of the side effects associated with it. But as part of that, they looked at reduction in density and saw that there was a significant reduction in density when they were treating women. So part of being high risk would include things like elevated density, asymmetry between left and right breast, microcalcifications. There's genetic factors, there's family history, there's BMI, there's alcohol and tobacco use. So if you look at all that, that's how they come up with this, who's high risk. But as part of that study, they did look and see that it reduces density. But there are no approved drugs, and to our knowledge, there are no other drugs that are being tested specifically for density reduction. All right, well then, thank you for your time.